that projects very nicely. You're welcome to start.
Thank you so much, Professor. Right, good morning, everybody. My name is Leo Skippers. I'm a medical officer in Gqeberha, Port Elizabeth. And this morning's topic will be regarding male infertility, the definition, evaluation, and management thereof. We're quickly going to be having a look at epidemiology, the evaluation, and the management of male infertility. Starting off with the definition of infertility, it's when a sexually active non-contracepting couple is unable to achieve spontaneous pregnancy within 1 year, subdivided into primary infertility and secondary infertility, where primary infertility is the inability of a couple to have ever produced children, and secondary is if they have previously had children but now is unable to achieve pregnancy either within the couple or with previous partners. Looking at the epidemiology, about 50% of couples do not achieve pregnancy within the first year of trying. Of these, 50% are attributed to male infertility associated factors, and between 30 and 40% of these are deemed to be idiopathic male infertilities. Looking at the causes, 42% of these patients are known causes, either from varicocele, male descendant testes, sperm antibodies, or as a result of testicular tumors. 30% are idiopathic, 10% as a result of hypogonadism, 8% of other associated tumors, and 3% is attributed to disturbances of the erections or ejaculation. Looking at the causes of male infertility can broadly be subdivided into non-obstructive azoospermia or obstructive azoospermias. Looking specifically at your obstructive causes, anatomical approach here works quite nicely. So looking at your intratesticular causes as a result of inflammatory conditions, trauma, or surgeries, your epidemial causes as a result of your cystic fibrosis gene mutations, the CFRT gene causing congenital bilateral absence of the vas deferens, or secondary to acute epididymitis. At the level of the vas deferens, vasectomy is the most common cause, but with these, you can also have obstruction as a result of hernia repairs or agenesis of the vas deferens. Looking at causes for obstruction at the level of the ejaculatory ducts, can either be as a result of cysts or as a result of post-inflammatory conditions, which was caused by either a urethritis or prostatitis. In addition to that, erectile dysfunctions, ejaculation, and retrograde ejaculations will also cause this. Looking at your non-obstructive causes, conditions that increase testicular temperature, varicocele, obesity, lifestyle, either taking warm baths or wearing constrictive garments, and hormonal abnormalities, especially your hypogonadism. Your genetic factors that play a role here is your sex chromosome abnormalities, your Y chromosome microdeletions, as well as the cystic fibrosis gene mutations that tend to cause bilateral absence of the vas deferens. Then coming to the evaluation of these patients, it's important to take a good medical history, particularly paying attention to whether there's a history of previous testicular cancer, whether they've had mumps or cryptorganism, previous surgeries to the inguinal region, either for inguinal hernia repair, pituitary surgery, or other urological surgeries. To take a history on regarding the patient's eating habits, are they exercising, the quality of the sleep, and their stress levels, and whether they are taking any tobacco products or alcohol. During your sexual history, it's important to gather the duration of the infertility, whether it's primary or secondary infertility, whether there is associated erectile dysfunction, cordia, or dyspareunia, as well as the age of the partner, and whether there's a history of sexually transmitted diseases. On general examination, it's important to note whether there's secondary sexual characterization, looking at the hair distribution or the presence or absence of gynecomastia. Examining the scrotum, focus is on the testicular size, the volume and consistency, as well as the consistency of the epididymis and the presence of the vas deferens. It's also important to palpate for varicocele. When it comes to the penis, it's important to evaluate whether there is a phimosis, whether there's any fibrotic nodules or plaques within the corpora, whether there's an epispadias or a hypospadias. Imaging modalities. Scrotal ultrasound is by far the most widely used imaging modality. It's used to evaluate the testicular volume, the presence of the vas deferens, to look at the quality of the epididymis, and to rule out potential testicular lesions. In the presence of obstruction, it is found that there is often dilation of the right testes, enlarged epididymis with cystic lesions, or there can be an absence of the vas deferens. Looking at the findings for testicular degenesis, often found to have non-homogeneous testicular architecture with the presence of microcalcifications. The use of transrectal ultrasound is done to evaluate the prostate, seminal vesicles, and ejaculatory duct. And with obstruction, the ejaculatory causes that can be found, there's ejaculatory duct cysts or prostatic cysts, and there is a presence of enlarged seminal vesicles. MRI can be used. It gives good anatomical definition, and it's able to establish the etiology or the site of the obstruction. When coming to semen analysis, ideally to have a semen analysis done on 2 occasions, 3 months apart, with 72 hours of abstinence prior to analysis. This is used to evaluate sperm count, sperm morphology, and sperm motility. When reporting semen analysis, this is done according to the WHO reporting system. If there is a presence of too few sperm, it's termed to be oligozoospermia. If there's poor motility, it's acinozoospermia, and if there's abnormal shape, it's teratozoospermia. And these conditions can be can be present altogether, and this is termed the AOT syndrome. In addition to that, extended examination can be done. During this, there's examination of whether there's inflammatory markers, whether there's sperm antibodies, a look at semen biochemistry, and as well as whether there's DNA fragmentation. With the evaluation of the hormone profile, the specific hormones here to look for is your FSH and LH, testosterone, estradiol, and prolactin. When it comes to the evaluation, in the presence of a raised FSH, normal LH, and testosterone, the diagnosis is most likely as a result of defective spermatogenesis. Where there's normal FSH, LH, and testosterone, it's most likely as a result of genital tract obstruction. If you have raised FSH and LH with a normal or low testosterone, it's as a result of potential testicular failure. And if there is low FSH, LH, and testosterone, the diagnosis is most likely to be a hypogonadotropism. When looking at genetic testing, your indications for karyotype analysis is if there is recurrent spontaneous abortion, if there is malformation or mental retardation, and in your semen analysis, if you have azoospermia or oligospermia. For your Y chromosome detection, especially for your azoospermia factor detection, again, this is a semen analysis showing azoospermia or oligospermia, and this is to detect whether there is AZF-A, B, or C microdeletions. For cystic fibrosis gene mutation, these patients often have a semen volume that's less than 1 mol with an acidic pH of less than 7. This can be in association with a non-obstructive azoospermia and the presence of a congenital bilateral absence of the vas deferens. When coming to DNA fragmentation testing, spermatic DNA can be damaged as a result of varicocele, chronic infection, lifestyle factors like smoking or alcohol use, as well as cancers. So the indication for DNA fragmentation comes from unexplained infertility, if there's recurrent pregnancy loss, or ART failure, which is assisted reproductive techniques. It can also have prognostic information for failed assisted reproductive techniques. So if there's a raised DNA fragmentation index of 25%, This could indicate that there will be a reduced pregnancy rates. If the value is greater than 50%, it's often associated with poorer outcomes from your IVF procedures. If the DNA fragmentation index is very high, it should be considered to use sperm from testicular sperm, to use sperm that's collected from the testes directly. When coming to the management, the aim is to identify and treat reversible causes of self-fertility and improve semen quality. So first of all, to look at lifestyle modification, to stop smoking, to reduce alcohol intake, to lose weight and start exercising, to manage stress more effectively, to avoid hot baths or restrictive garments. Looking at your hormonal therapies, so this is just a schematic of the axis. So your follicle stimulating hormone acts on your Sertoli cells. This stimulates your spermatogenesis, whereas your luteinizing hormone acts on your Leydig cells, which stimulates testosterone production. Selective estrogen receptor blockers has been proposed as a potential empiric treatment for these patients. They block estrogen receptors in the hypothalamus. This results in stimulation of GnRH secretion, which in turn stimulates the pituitary to secrete FSH and LH. Human chorionic gonadotropin stimulates testosterone. In addition to that, it can also stimulate spermatogenesis in patients with hyperpituitarism that has a normal puberty. Aromatase inhibitors reversibly inhibit aromatase enzyme complex. This results in a decrease in estrogen production, which in turn inhibits the negative feedback of estrogen on the cycle. Your clomiphene citrate, this blocks your feedback of estradiol, in turn increasing your FSH and LH. So this is a bit of a busy slide, but I'm trying to put the above mentioned treatments together and a little bit better defined here. So when to start the treatment is reliant on your testosterone level as well as your testosterone and estradiol ratio. So looking at a low testosterone level of less than 300 nanograms per deciliter in association with a low testosterone estradiol ratio, which is less than 10, the treatment would be aromatase inhibitors. If your testosterone level is low and your testosterone estradiol ratio is raised, then the treatment should be human chorionic gonadotropin. And if your testosterone is raised and your ratio is low, aromatase inhibitors should be given. So the aim of this is to have a testosterone greater than 800 nanograms per deciliter and a testosterone estradiol ratio of greater than 10. This should be for a minimum of 3 months with a repeat semen analysis after 2 to 3 months. Looking at the management for obstructive azoospermia, these patients have normal FSH, normal testis examination, and normal spermatogenesis. The management here is most often surgical correction with the aim of conceiving naturally. If this is not possible, to retrieve sperm for assisted reproductive techniques. So the management for obstructions at the level of the epididymis or the vas deferens is through microsurgical reconstruction, either through a vasovasostomy or a vasoepididymostomy, where a vasovasostomy, the obstructed segment is resected and the end-to-end anastomosis is done. In your vasoepididymostomy, the anastomosis of the vas deferens to the epididyal tubules is done. So with these techniques, you have a 90 to 97% patency rate, between 50 and 72% pregnancy rates, and the average time to patency is 1.7 to 4.3 months, and late failures tend to be uncommon, somewhere in the range of 0 to 12%. When it comes to the management of obstructions at the ejaculatory duct, these patients are found to have low semen volumes of less than 1.5 moles, acidic pH of 7.2, And the management here is a transurethral section of a ejaculatory duct. This is for down through the midline for intraprostatic cyst. They are incised or unroofed or aspirated. In the same setting, you can do a transrectal ultrasound-guided aspiration of seminal fluid for assisted reproductive techniques. For the management of ejaculation, it's common. The common causes for this is idiopathic spinal cord injury or as a result of retrograde lymph node dissections. The management here, if the reflex arc is still intact, is electroejaculation stimulation or through vibratory stimulation. So the management of retrograde ejaculation, so these patients have a cause pertaining to spinal cord injury. They report a dry ejaculation or have a low volume of less than 1 ml. They report that the first urination after ejaculation can be cloudy, and this is confirmed on urine analysis where you have more than 10 to 15 sperm per eye field on microscopy. The management for these patients is ideally, or first line is pharmacological in the form of alpha agonists or tricyclic antidepressants. So if this is not possible to produce a prograde flow of semen, then you can opt for semen retrieval. So this is done by giving sodium bicarbonate 60 minutes before ejaculation. This will optimize the osmolarity and the pH of the urine. Sperm is then collected by gently centrifuging the urine sample out, and then the collected sperm can be used for assisted reproductive techniques. When looking at specific sperm retrieval techniques, percutaneous epididymal sperm aspiration. This can be done under local anesthetic. It's done by placing a butterfly needle into the head of the epididymis, and then through negative pressure being applied, the sperm can be aspirated. Your microsurgical epididymal sperm aspiration, or MISA, is done under general anesthetic. It's an open procedure. The microscope is used to retrieve sperm from the epididymis. Your testicular sperm aspiration, or TISA, is done under local anesthetic. It's minimally invasive and can be done in an office-based procedure. Testicular tissue is retrieved via a biopsy needle. Your testicular sperm extraction, or TC, this can be done either locally or general anesthetic. There's a scrotal incision and an open biopsy of the testis is performed. Your microtesticular extraction of sperm, or MTZ, and again, this is a scrotal incision is made. The microscope is used to inspect the seminiferous tubules. Then extraction is done from your large dilated and opaque tubules. Looking at the indications for the different techniques. So for your obstructive azoospermias, PISA and MISA are the preferred techniques. When looking at the indication for testicular sperm aspiration, if there was a previous failed percutaneous epididymal sperm aspiration, if there's epididymal agenesis or absence of the vas deferens, or if there was a previous successful testicular sperm aspiration, then the indication for your testicular sperm extraction, either conventionally or with microsurgical techniques, this is most often done for your non-obstructive azoospermic cases. Keeping in mind that patients who have non-obstructive azoospermia, these patients often have spermatogenesis within the testicle that is focal in nature. So fine needle aspiration mapping is used then to map sites with higher probability to retrieve sperm from. When using this map, if there is multiple sites of positive or high probability of receiving sperm, the methods employed should be a TISA or TZ. But if there is few positive sites, then your micro TZ should be employed. This is just a demonstration of the grid pattern that is placed on the skin before the fine needle aspiration mapping is done. When looking at the success rates of this retrieval, looking at your obstructive azoospermias, whether it's done percutaneously or microsurgical, both of these have about a 90% success rate. And when looking at your non-obstructive azoospermias, there's a significant improvement in success rates when using microsurgical techniques, up to 50% as compared to 35%. Short notes on assisted reproductive techniques, looking at intrauterine insemination, in vitro fertilization, and intracytoplasmic sperm injection. Your intrauterine insemination, sperm is placed into the uterine cavity. This can be timed around ovulation as a result of other stimulated cycles. If a stimulated cycle is used, it increases the available folioles for fertilization. In vitro fertilization, ova are mixed with processed semen. The embryos are incubated for 2 to 3 days in a culture before being placed transcervically into the uterus. Your intracytoplasmic sperm injection, a single sperm is injected directly into the egg using a glass micropipette, is by far the most common form of assisted reproduction techniques being employed at the moment. So your outcomes of assisted reproductive techniques, more than 4 million babies have been born since its inception in 1978. There is, however, birth defects have been associated with assisted reproductive techniques. There is about in the range of 30 to 40% increase in major malformation, although there is a debate regarding what the actual cause is for this, whether it be from paternal age or the intrinsic defects in spermatogenesis of infertile men. So in conclusion, the take-home message here is that male factor infertility should be managed in specialized centers with a multidisciplinary team. Both partners should be investigated to categorize the etiology and maximize the chances of successful pregnancies. And thank you very much.
Thank you, Dr. Skeppers, for a well put together talk. Thanks for your hard work. I'm just seeing if there are any questions on the chat. I think urologist role in infertility is somewhat constrained or confined rather to being part of multidisciplinary teams to manage these patients. Certainly that's the case in our center. And I suppose varicocele repair, on the odd occasion, vasovasostomy, etc. Those are the kind of roles that we play. But certainly we see a lot of patients at a more primary level who would come to us asking for answers about infertility. And it's quite helpful to have a classification in your head for causes for infertility based on the spermogram, on the semen analysis. Do you have a classification, Dr. Skeppers, that can be helpful for the practicing urologist?
I did not prepare any classifications, unfortunately, Professor.
Sure. Also, I think it'd be important to emphasize a little bit the most common of those causes would be the Oates syndrome. What's that?
So it's a combination of abnormalities in the number of sperm, the motility, as well as the morphology. So it's a combination of all three of those.
Yes, correct. I think that's said to be the commonest abnormality that is found. And how would you manage those men?
So, Professor, I think it's important to start with your lifestyle modifications first, and then, yeah. So to start with lifestyle modification, I think you've got me there. I'm not, yeah.
Yeah, no, I think you're on the right road. It's those things that you mentioned right at the beginning, many of those soft things, such as alcohol, stress, etc. Those are the kind of any toxins that you might be able to identify, sleep, etc. Those are the things that are said to improve the Oates syndrome. Just looking if there are any further questions. I think the new kid on the block would be clomiphene citrate. Which man would you offer that to?
Professor, if I may maybe quickly go up to my slides regarding clomiphene. So these would be in patients that would have a raised estradiol levels compared to your testosterone. So the idea of giving clomiphene citrate would then to reduce your negative feedback loop from your estradiols, hoping to either then keep the forward momentum of your axis, hopefully to increase your FSH and LH production, which in turn would stimulate your testicle to undergo spermatogenesis.
Yeah, I think that's well said. So it's in hypergonadal men, and specifically men who have got primary hypergonadism or hypergonadotrophic hypergonadism. So these men, you typically give them supplemental testosterone, but if they're trying to preserve their fertility, then testosterone is obviously going to worsen the situation. That might be the role for clomiphene as I have it. I'm desperate for one further question for Dr. Skeppers. Colleagues, anybody got a question? Leo, thank you very much for your contribution and for keeping to time. We're going to move on to our second talk. Right, we've got a hand up, Dr. Crowley. Welcome, Lonwaba. How are you?
Very well, thanks, Prof. I wasn't going to say anything, but you said you were desperate, so I thought I'd make one quick comment. It's just on the one point, on the definition when you say sexually active, I know Professor Mtambiro always used to ask how to define exactly what is sexually active, for the purposes of advising a couple. And generally, I don't know if Leo, you know the answer, but, we were always told at least once every 3 days as a minimum should be sufficient if in a couple who's trying to conceive. But yeah, that's just about the comment I was going to make.
Yes, Dr. Crowley, I have it as at least 3 times a week. So I think it will come very close to the same.
Thank you, Dr. Skeppers again. And we're going to move on to Dr. Elisha Roeder, a colleague from University of Cape Town. He's going to give us our second